Excellent. So good afternoon, everyone. My name is Sarah Dugan. I'm a psychiatric pharmacist and faculty at the College of Pharmacy. Our topic for today is psychiatric adverse effects of the angiotensin receptor blockers. So from an objective perspective, I hope to list the prevalence of the psychiatric adverse effects that we've encountered with the angiotensin receptor blockers, to identify any factors that might increase the risk for developing these adverse effects, and then we'll take a look at the literature that has revolved around this particular topic. So before I get started and delve into the literature, I just wanted to do a quick review of the renin-angiotensin system. So we have angiotensinogen, which is a compound that's created in the liver. It is acted upon by renin, which converts it to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 using the angiotensin converting enzyme. So angiotensin 2 is responsible for arterial vasoconstriction, and then it also has some actions in the adrenal cortex where it can impact aldosterone. So aldosterone tends to be involved with sodium and water retention. So why all of these pieces? Well, the actions of the angiotensin receptor blocker, so the class of medicines that we're going to talk about, really are going to be right after this green box here. So it's going to block the actions of angiotensin 2 on the receptors. So in one aspect, it will lower blood pressure. So you can't get vasoconstriction, so those blood vessels will stay more dilated. And then in the adrenal cortex, it's going to prevent the actions of aldosterone. So we can see lower aldosterone levels. We can see more water loss. So we really tend to encounter most of these medications in a cardiovascular primary care type environment. Patients who have high blood pressure, patients who have congestive heart failure, patients who may have previously had a heart attack, this is really where most of those actions are going to be. Now, I do just want to point one thing out. It has been suggested that the aldosterone may potentially play a role. Aldosterone and angiotensin 2 may potentially play a role in other substances. So substance P being one example. So substance P concentrations, when they go up, have been associated with both stress and anxiety. So maybe that might play a role in some of the adverse effects that we're going to see. So what are the medications that we're looking at? So this class of medications in particular are competitive antagonists of those angiotensin receptors. So right after that green box, it's going to block the actions of angiotensin 2. We have several different compounds that are available. They're used to different extents, depending on the practice area that you're in. For the most part, the evidence that we're going to talk about today, let me make sure I'm accurate in saying that, is all retrospective. So we're really looking backward. The assumption that we can make is that the vast majority of these cases are going to be within the normal dosing ranges. There is one study that looks at the breakdown of doses, so we will talk about that a little bit. But for the most part, we're going to make the assumption that most of the medications have been used within the normal dosing range. So this topic was brought to me. Many medications can have all kinds of different adverse effects. Psychiatric adverse effects are not a common one that has been identified with angiotensin receptor blockers in the past. So I wanted to look, well, what was available initially? And this case report was one of the first ones that popped up. So this was a case report on a 31-year-old female, African-American. She had no prior diagnosis of any mental health conditions. She had a number of medical conditions. She had mild intellectual disability, hypothyroidism, hypertension, chronic kidney disease, and congestive heart failure. So she was on a large number of medications. In a routine visit with her primary care provider, there were some dose adjustments that were made. One of the dose adjustments was to her sacubitril valsartan, so valsartan being one of our angiotensin receptor blockers. The increase in the dose of that resulted in, over the course of the next 7 days, an increase in mental health symptoms that she had never experienced before. So aggression, confabulation, delusions. She had auditory, visual, and tactile hallucinations, specifically related to insects. She felt that she could see insects, hear insects on the wall, and that she could feel them on her skin, which became so severe that she actually was excoriating her skin to try to get rid of the insects. She had some nighttime wandering, paranoia, as well as sleep disturbances. This resulted in hospitalization. So, new onset of these symptoms, they increased in severity over the course of those 7 days. She was admitted to the hospital, and the treating team held all of her medications. Within 24 hours of holding her medications, she had improvement, if not resolution, in the vast majority of those symptoms. So the medications were held for a subsequent day as she was discharged from the hospital and encouraged to follow up with her primary care provider. So she did follow up with her primary care provider, started her medications back, and those symptoms recurred. She again became aggressive. She had delusions, hallucinations. She had some fecal smearing throughout her house and continued to have the hallucinations related to the insects, to the point that she was pouring cleaning supplies all over the furniture and the walls. She was bathing in the cleaning supplies as well as trying to ingest it. So they readmitted her to the hospital, at which time they again discontinued her medications, symptoms resolved. As they went back in the timeline to kind of see, okay, what happened before these symptoms popped up, they did see that dose adjustment to the sacubitril valsartan, and they said, well, maybe that's responsible for it, initiated her other medications, had no recurrence of these symptoms. So these symptoms were attributed to that particular medication. So to be fair, this is a combination medication, so it has the neprilysin inhibitor as well as the angiotensin receptor blocker, but it did appear something was going on with that particular product. So I wanted to see what other information I could find. So one of the studies I was able to come across was a nested case control study. So this was a study that was conducted by investigators that were in Denmark. They used the National Registry, and they specifically were looking at the National Death Registry. They were evaluating individuals who had completed suicide from 1991 through 1998, and they wanted to compare drug exposure in those patients. So they looked at a handful of classes. So lipid-lowering medications that included the statins, the fibrates, bile acid sequestrants, nicotinic acid, and any derivatives thereof. ACE inhibitors, angiotensin receptor blockers, beta blockers, as well as calcium channel blockers. So they matched the 743 patients who had completed suicide with 14,860 control patients. So individuals who had passed away at the same age, they did age and sex match. So if it was a 46-year-old female that had completed suicide, they found a corresponding 46-year-old female. These individuals, the average age was 53 in the patients who had completed suicide, and approximately 68% of them were male. Patients who had completed suicide were more likely to be treated with anti-diabetes medication. They had been on anti-seizure medications, as well as psychiatric medications, antidepressants, antipsychotics, mood stabilizers, benzodiazepines. So recognizing that the individuals who had completed suicide were more likely, they also wanted to evaluate were any of these cardiovascular medications present more frequently in those individuals who had completed suicide? So they developed an odds ratio. So the likelihood that they were on this medicine and they completed suicide. For the other classes of medication, the calcium channel blockers, the beta blockers, the ACE inhibitors, and the lipid lowering medication, there was no difference. So they did not see that these medications occurred more frequently in individuals who had completed suicide versus those who had not. For the angiotensin receptor blockers, they did see an increase. So the odds ratio was 3.5. So individuals who had completed suicide were 3.5 times more likely to be on the angiotensin receptor blockers, which was a little bit of a surprise. The authors really had anticipated they'd see a difference with some of the other medications, including the beta blockers, and that's not what they found. So it did look like there was a potential risk. There was another case control study that was done. So recognizing what they had found with the Denmark database, there were additional researchers that wanted to evaluate this again. So was that an anomaly? Is this something that we could see? So these investigators used the Canadian database. So they have a national health system. They have national databases that they're able to review causes of death, diagnoses, medication that patients are on. So they also conducted a population-based nested case control. So their cases were individuals who had died by suicide. They included only individuals who were 66 years of age or older. So there was not an age cutoff for the Denmark group. This really was focused a little bit more on an older population. There were 964 individuals who had completed suicide that were over the age of 66. And they also had included individuals who had received a prescription for any ACE inhibitor or angiotensin blocker within 100 days of committing suicide. So they had to have that prescription, and they were looking specifically, did they continue to see that there was an increase? They added their control group. There were 4 control patients for every patient who was considered a case, so an individual who had completed suicide. They matched these patients by age, sex, presence of hypertension, and diagnosis of diabetes. So if the patient who had completed suicide had hypertension, and maybe they were a 70-year-old male, then the matching control cases would all be 70-year-old males who had hypertension. So what they found was the percentage of patients that were exposed to ACE inhibitors or angiotensin receptor blockers was a bit skewed in both cohorts. So for the cases, the individuals who completed suicide, about 73% of those patients were on an ACE inhibitor compared to 27% that were on an angiotensin receptor blocker. In the control group, 80% of the individuals were on an ACE inhibitor, and only 20% of them were on an angiotensin receptor blocker. When they evaluated the individuals, they again found an adjusted odds ratio that individuals who had passed away due to suicide were more likely to be on angiotensin receptor blockers. And this was a little bit more powerful because the percentage of patients on those angiotensin receptor blockers was much smaller. So despite the fact that it was much smaller, they still were seeing this significant signal. Now, neither of these case control trials are able to demonstrate causality. They just are able to identify an association. So is it possible that individuals who are on angiotensin receptor blockers were less likely to tolerate other medications, which is why they ended up there? That's a possibility. They also were one of the first ones to really explore maybe it had something to do with changes in that substance P concentration. So by blocking the ACE inhibitors would not create angiotensin 2. Angiotensin 2 is one of the signals for substance P, which may result in stress and anxiety. The angiotensin receptor blockers would still allow for production of angiotensin 2, which may then result in the signal for substance P. They're only blocking the receptor. So that actually would leave that compound able to go move and interact other places, thus potentially raising substance P, resulting in stress and anxiety. Now, caveat to that, there has not been a direct correlation between substance P levels and suicidality. So yes, it may be a factor, but again, nothing has been able to be clearly proven at this time, other than there definitely is a signal for those patients on angiotensin receptor blockers. So let's look beyond suicidality. What about some of the other conditions? So this was a study that was done. It was a retrospective cohort study. This was a Taiwanese database, and they were looking at patients who had been on an ACE inhibitor or an angiotensin receptor blocker for at least 28 days. And they used the time frame between 2000 and 2012. This included almost 14,000 individuals that were in each category. So 13,974 patients that had received ACE inhibitors or angiotensin receptor blockers for at least a month. Now, they had two different cohorts that they looked at. So they looked at individuals who, no, I'm sorry, the next one has two cohorts. They looked at individuals who had a major psychiatric disorder. So if they'd gotten an ACE or an ARB, they then were looking for, did they subsequently get diagnosed with some type of mental health condition? Now, the mental health condition needed to not be acute. It had to be present for at least 2 visits. So if somebody potentially was very ill and they had been put on steroids and they show up for an appointment and they have symptoms of mania, that would only be 1 visit, with that being discontinued and going away. So they really were looking for an actual diagnosis for a condition that was going to continue. What they found was that the development of psychiatric disorders was seen more frequently in patients who were older, in women, and in those patients who had more comorbid medical conditions. So if they had more medical conditions, they were much more likely to be diagnosed with a psychiatric disorder. When they looked at the 2 classes of medications, so this is exposure to ACE inhibitors versus exposure to angiotensin receptor blockers, and they both have adjusted hazard ratios. So for the ACE inhibitors, because this was one of the comparator groups, they found that they were more likely to have psychiatric conditions if they've been on the ACE inhibitor for at least 65 days. So those that were in the 65 to 245 day category were more likely to have a diagnosis of a psychiatric disorder, and those who had been on treatment for more than 245 days. When they looked at doses for the ACE inhibitors, they found that the moderate and higher dosing category, so they actually pooled these as doses per month, doses per year. So this wasn't daily dosing, so that's why those numbers look a little different. But essentially, they were trying to categorize low-dose ACE inhibitors, mid-dose ACE inhibitors, high-dose ACE inhibitors. So the mid and the higher dose ACE inhibitors, those individuals were more likely to be diagnosed with a psychiatric condition. For the angiotensin receptor blockers, the information was just a little different. So they had different threshold cutoffs for duration of treatment. I'm not exactly sure why they did it differently, but they did see a difference for those who had been using angiotensin receptor blockers for less than 220 days, or for essentially a year or longer, so for greater than 350 days. So both of those were more likely to have a psychiatric diagnosis. And again, with the dosing breakdown, those that had mid-range dosing or were at the higher end of the dosage range were much more likely to have a subsequent diagnosis of a psychiatric disorder. So again, cannot demonstrate causality. So not saying that the ACE inhibitors or the angiotensin receptor blockers are causing the psychiatric disorder, but just interesting that there is an association. The higher doses were much more likely. The longer that they were on these treatments, the much more likely they were to get that psychiatric disorder. To be fair, one of the confounders there would be that suggests that a patient has an uncontrolled medical condition, excuse me, an uncontrolled medical condition, which may make it more likely that they develop a psychiatric disorder, depression, anxiety, for example, in patients with uncontrolled cardiovascular disease. So I wanted to see if we could find something that helps a little bit more to try to tease apart what's happening as a result of the medications versus what's happening as a result of the conditions. So I was able to find this study. So this was also a cohort study. So this looked at electronic health records. So they included electronic health records for more than 54 different healthcare organizations. This included hospitals, primary care providers, as well as specialty clinics. They included all adult patients between the ages of 18 and 90. The average age was between 59 and 60. And they were looking at exposure to a number of cardiac medications. So ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, or diuretics. And they wanted to follow these patients for at least 2 years. So this cohort was able to look at almost 60 million patients. They split them into 2 different groups. So one group did not have an existing psychiatric diagnosis. So they were looking at a new subsequent diagnosis of any of the mental health conditions. The second cohort explored how many patients on these particular medications then essentially had a recurrence of their existing condition. So if they had major depressive disorder, for example, how many of them then had an exacerbation of their major depressive disorder, an increase in those symptoms that required intervention. Interestingly, between those 2 cohorts, so getting a new diagnosis of a mental health condition or having an exacerbation of your existing mental health condition, was incredibly consistent across the board for the angiotensin receptor blocker group. So the number of patients that they included that were on ARBs was just under 200,000 patients. 46% of them were male, and their average age was 60. So in looking at our chart here, the blue bars are cohort 1. So these are patients on angiotensin receptor blockers that got a brand new diagnosis. So there were 45% got a diagnosis for an affective disorder, 44% for anxiety disorder, 4% for bipolar disorder, 40% for major depression, 2.5% for a psychotic disorder, 0.9% for schizophrenia, 32% for a sleep disorder, and 14% for substance use disorder. Interestingly, you see those yellow bars are almost identical. Now, these were the cohort 2 patients, so patients who already had these conditions but had an increase in those symptoms. So 45% of the patients with an affective disorder, so that included both bipolar disorder, major depressive disorder, and any other mood episode that increased. 40% for anxiety disorder, 3.7% for bipolar, 41% for major depression, 2.1% for psychotic disorder, 0.8% for schizophrenia, 31% for sleep disorder, and 14% for substance use disorder. So interesting that it was very, very similar. I think I had anticipated going in that the individuals who had a recurrence of symptoms might be a higher percentage than those new diagnoses. So maybe it's possible that individuals who have comorbid conditions that need to be on these medications are just more likely to develop these psychiatric conditions. But some of those cohorts, including the suicidality data, suggest that maybe there's something else that's going on. And interestingly, just real quick, because the focus today was on angiotensin receptor blockers and psychiatric adverse effects, one observation I wanted to make here, though, is the calcium channel blocker group and the ACE inhibitor group both had greater percentage of patients who developed a new diagnosis or had somebody have a recurrence of symptoms. So across the board, we were seeing an increase in all of them, but they saw even more with those other two cardiovascular medication classes. So ARBs weren't the worst. So in recognizing that there does seem to be a little bit of a signal for some mental health symptoms, it's not something that we see reported in the package insert information or in the tertiary literature. So candesartan does have anxiety, depression, and somnolence listed. It's at 0.5% or greater. That's the information that came from clinical trials. Losartan was depression and sleep disorders in less than 2%. Telmisartan had anxiety and depression, again at 0.3% or greater. And then valsartan had anxiety listed at 0.2% or greater. Now, why does it say 0.2, 0.3, 0.5% or greater from clinical trials? What they had noted within the prescribing information was they weren't able to determine if this adverse effect was actually due to the medication or just something that happened to the patients because of the other conditions that they had. So hypertension patients, for example. So that's really what that asterisk is. So yes, it was happening. Is it from the medicine? We haven't been able to determine that causality at this time. So it seems like there is a signal, but that's not all of the information that's out there. There have been a number of confounding reports that demonstrate evidence in the opposite direction. There were lower rates of depression in patients that were taking angiotensin receptor blockers and had hypertension compared to other antihypertensive medications. So I guess it doesn't mean that it's always going to cause depression. In some cases, it looked like it was less likely for those patients to develop depression. There was a lower prevalence of the diagnosis of bipolar disorder in patients taking ARBs than those taking other antihypertensives. So that includes things like beta blockers, calcium channel blockers, ACE inhibitors, which I found a little bit interesting. Things like calcium channel blockers are occasionally used for refractory bipolar disorder. So seeing that it was less likely to occur in patients who were on ARBs, again, suggests that maybe there is a signal in the opposite direction that for some cohorts of patients, it can be beneficial for their mood symptoms. There have been, there's been no association. I tried to make that very clear. We don't have causality. We can't prove that the angiotensin receptor blockers are responsible for those psychiatric adverse effects that we're finding. Yes, there are other comorbid conditions. That's why they're on these medicines. So is it because they have that condition that we would use an ARB that then increases the risk for the development of these other symptoms? Or might these medications play a role? And I think that's where we really need to do some additional research. But recognizing the evidence that is available, there have been psychiatric symptoms reported in patients who are taking these angiotensin receptor blockers. So it encompasses the entire spectrum of symptoms. And we saw a signal in at least 2 different database studies that individuals who had completed suicide, there were more of those individuals who were actually on angiotensin receptor blockers. So that might be a little bit more of a higher risk patient population. Yes, they had some other conditions, but that may be a screening we want to make sure is being done pretty robustly in patients who are even on some of these other classes of medications. Those who are on angiotensin receptor blockers for a longer period of time, those who are a bit at higher risk or at higher doses may be at higher risk. So those would be potential target populations if we wanted to really hone in on who we might be worried about for that. But at this point, that's what we have. There seems to be some association with an increase in those symptoms. Is it due to it specifically? Maybe, but that may be an indicator for other things we just need to be mindful of and make sure we're screening for. So that is what I have for today. So I will